Hello, my name is Amy Smallwood, and I am presenting to you on my project for Steps to Recovery, which is an early mobility initiative that we did to promote safety in the intensive care unit. So a critical illness or a severe injury typically lands a patient into an intensive care unit, which traditionally has led to immobility due to time-honored therapeutic bed rest that we thought the patient needed to rest in order to heal. However, we have realized that immobility leads to ICU acquired weakness, which contributes to an outcome of increased ventilator days and increase in the patient's length of stay. While in ICU, a patient can have 1 to 5% muscle loss per day, and once they reach 40% muscle loss, this could equalize out to about 100% mortality rate. However, early mobility, which is mobilizing the patient within 24 hours, has been proven to combat ICU acquired weakness, decrease ventilator days, and decrease length of stay, which ultimately leads to better outcomes for the patients and safer care. Knowing that a patient needs to go against that natural flow of immobility in the ICU and the need for early mobility, the trick for this project was to figure out how to make that happen with an early mobility protocol. Using the evidence as a guide, the key elements to a successful early mobility project includes having various levels of mobility to define what is safely to be performed at each level, that is progressive in nature in order for the staff to continue to move the patient along that continuum, and contains inclusive, exclusive criteria to help guide the staff on when a patient should or should not participate. There are many views out there of whether this should be a nurse-driven or physical therapy-driven process. However, due constraints at the current facility that we are working in, this project was set up as being a nurse-driven process that was complemented by physical therapy. Knowing what needed to be done for the project, the second step of this planning was to come up with the goals that would be used to guide the overall project. The structure goals was to implement the early mobility protocol with an exercise algorithm containing those key elements we just discussed. The process goals are to start the patients on the early mobility protocol within 24 hours of being admitted to the ICU or as soon as clinically stable to progress into the early mobility program. The second one is that each patient will then need to complete a daily exercise regimen according to their mobility level that is outlined in this protocol. The outcome measures will be to reduce the ventilator days and reduce the overall ICU length of stay. This table summarizes the thresholds of each of the 5 goals, showing that the early mobility protocol being implemented meets that metric. The 2 process metrics will be set at a 90% compliance rate, and the ventilator days will have a goal of reduction of 10%, and the ICU length of stay will have a reduction goal of 20%. The project design will help outline the where, when, and how the project will actually take place. So this project is being implemented at a tertiary level hospital that has 566 licensed beds, but particularly in the 14-bed medical ICU within that hospital. The time period for this project ran from March of 2017 to May of 2017, with the goal again of being every patient started on the protocol within the first 24 hours of admission. The primary nurse will use the protocol to determine the appropriate mobility level, And then that patient will continue to progress to the next level of mobility once that is appropriate per that algorithm. Progression will continue until the patient is either discharged or returns to their baseline mobility. So prior to kicking off, now that we had our project methodology outlined, it was very important that we sat down and went through with the key staff for this project all of these specific elements that they needed to be aware of. First element for staff education is the effects of immobility. Not all the staff understood what immobility would do to an ICU patient. Those statistics of muscle loss and the mortality that could be associated with that and the long-term complications were important for them to understand, to then have the desire to do something different and implement an early mobility protocol. They had to be taught what the protocol was and how to appropriately use it. And a key element was that safe patient mobilization techniques needed to be reinforced with the equipment and resources we had to prevent the patients and or staff from being harmed in the process. A few of the concerns that came up during the education were potential barriers or perceived barriers by the staff that then we needed to address. A few of those things were patient lifts. We have the fortunate ability to have lifts that are built into all of the ceilings of our ICU rooms. However, not every room had a motor for the lift, which required someone to come in from facilities and move it each time. So one of the things we did prior to go live was ensure that all 14 of these rooms had a motorized lift installed, so this would not be a barrier. Appropriate sedation levels are certainly needed for the patient to be awake and alert enough to participate in the mobilization exercises as well. Coordinating all the disciplines together, so that really involved when should physical therapy or occupational therapy be involved, the involvement of respiratory therapy if a patient is on either a ventilator or other type of airway assistance, to making sure that all the disciplines are on the same page so that we do not have any barriers in coordinating those events to that patient to mobilize. The biggest barrier that we came across was what early mobility protocol did we feel fit our organization, and looking at all the desires, wishes, wants, and needs of the organization and our staff and our patients, we realized that there wasn't one that really fit that match perfectly, which led us down a path of creating our own individualized protocol to make sure that all those key elements that were needed were the right fit for our staff. This is our protocol that we came up with in the end. So I'll spend a few minutes going over this. It can be a little overwhelming at first, but if you start where it says start here, it runs through a series of questions to determine what level the patient should begin their mobilization. So it's basically asking, is this patient stable enough to be sitting upright in a chair type position, or should this patient still be very passive in level 1 and be laying flat with the head of bed just slightly elevated at 30 degrees? Once those criteria questions are gone through, the next section in the middle of it is contraindications of patients that should not participate due to what's occurring physically with that patient, and then some considerations just to think about things such as weight-bearing status and check for limitations that are written as physician's orders already, maybe from a trauma, and orthopedics has written some restrictions. Across the bottom are the 5 levels of mobility from passive up through walking, with listed exercise under each one of those mobility levels, and the little arrows or keys of when to move the patient from, say, level 2 to level 3. They must be able to hold their arm against gravity. This is posted in all the patient's rooms, and a minimum of every shift, the patient's level must be reevaluated, and they mark on their patient communication boards in the room which level that patient is on currently, so all staff are aware of that mobility status. They're also discussed daily in the ICU rounds, which involves the physicians, the respiratory therapist, the physical therapist, the primary nurse, and many others, but they will focus in on this and make sure that that patient is at the appropriate level and everyone is in agreement with that exercise algorithm for that patient. So this is again those 5 goals, and this just shows what our baseline metrics were for each of those compared to what the goal was. And really the important part of this is where we are getting that data from. It's very important that you know where you're getting the data and we don't just say that we're going to measure without an ability to. So the 2 process measures will be measured by monthly chart audits. The remaining 2 outcome measures will continue to be measured via the infection control report and case management report, which is the consistent way that these things have been reported in the ICU. The baseline data metrics are measured from March of 2016 through May of 2016, so they're mirroring months in the prior year to use as a baseline. So after 90 days of monitoring this program of being implemented, it was time that we really needed to assess the outcomes and see what our results are. So since we had this early mobility protocol in place, our structural goal, our foundational goal had been met. So we were going to look at the 2 process goals and 2 outcome goals. Our process goals for the protocol compliance were in the 2 categories. For the 3 months, again for March through May, we did 20 chart audits per month, selected randomly, looking at the documentation to see if the patient began that exercise of that early mobility within the first 24 hours of ICU. They were excluded if they did not meet the stability criteria to begin the program. So you can see each month we progressed and from how many charts out of the 20 that were compliant. The second part of that is, did each day they complete an exercise algorithm according to what their mobility level said. Our barrier here was that staff were saying they were completing, but there were some inconsistencies in documenting that. So we continued to work on the education of where to document and give themselves credit for each of those. So with this, it shows that our beginning it within 24 hours actually came to a 90% compliance average overall for the 3 months, and the daily exercise at 92% compliance. So these goals were both met since their goal was for a 90% compliance rate. Looking at the outcome measures, the first graph we will look at is the ventilator days for the medical ICU. This graph has the blue line is all of 2016 by month, and so we overlaid 2017 implementation phase of those 90 days on top of it. So circling in on these 3 months here, our baseline data from 2016 again shows that our average for those 3, or the mean, was 151 days. Our implementation period actually came out with 135 days, which then is a reduction of slightly over 10%, which was our goal of 10%. So we did just slightly over accomplish that goal, of which we are very proud of that reduction. The second goal is looking at length of stay, same concept as the graph before, with the blue line being 2016 and the orange line overlaid is the 2017 measurement period, looking at again the same 3 months. A baseline from 2016 was 4.88, with our implementation actual of being 4.13. This gives us a reduction of 12% in length of stay in just comparison of those 2 90-day periods. This is a significant reduction. Although it didn't meet our 20% goal, we are still very pleased with the progress at this point. So what do these outcomes mean for us in practice? So the ventilator days being decreased significantly decreases the risk of ventilator-associated pneumonia or other ventilator-associated events. But from a really patient-centered care perspective, it increases their ability to accelerate their recovery. They can be up easier, they can communicate with their family in a more clear manner, they can communicate with the nursing staff, and we're able to get them more back to a baseline status a little bit faster than if they're remaining on that ventilator. For length of stay, of course, the longer someone's in the hospital, the higher risk they have of getting some type of hospital-acquired condition. So a decreased length of stay certainly decreases that risk. But from the not only patient perspective, the huge benefit also is it for the organization, for the drastic reduction in length of stay. Not only opens up beds, but this could be a cost savings using a very conservative financial model that was published by Lord and Associates in 2013. Using a 12% reduction could easily equate to at least $780,000 of annual savings due to that extreme cost of ICU care. So some limitations, of course, did come up throughout this study. It's certainly not or this project, it's certainly not perfect. Some of the limitations that we experienced is it is a single setting. It is a smaller sample size, only being a 14-bedded unit over a 90-day period also helps kind of put some limitations on that. It's maybe not perfect data to say it's applicable in all areas. So what do we do from here? Early mobility was certainly proven to be safe and effective during this 90-day period. In our MICU, there were no serious safety events. There were no outcomes related to mobilizing these patients that were of any negative effect on the staff or on the patients, of course. Some of the 6 things that made it so successful is that being nurse-driven for us really empowered our frontline nurses to provide that holistic care and be able to continually move that patient along that exercise algorithm and that protocol to get them back to their baseline function and accelerate that recovery much sooner than waiting on the traditional model before of physical therapy coming in and being consulted on maybe even day 2, 3, or potentially not even while the patient was in ICU at all. The team approach was certainly vital in this, the coordination of respiratory and all the therapy staff to make sure that everyone was on the same page with the product was very, very important. The frontline staff engagement certainly helped. They were energized. They really wanted to do this. It was something that they were certainly open to. They just needed the tools to help guide them in the right direction. So our next steps is we're going to continue to monitor, reinforce until we get this completely hardwired. 90 days is certainly not enough time to claim hardwiring, but we will continue to do that until we feel that it's part of our culture and they would not expect to do it any other way. We will begin working on implementing this in our other ICUs at our facility. Possible additions to the algorithm or protocol might be needed to make it applicable to all of them. And we need to modify this out to the medical surgical floor so that when a patient leaves ICU, they're not completely done with their mobility process and it continues on in the appropriate manner throughout their hospital stay. This is some of the key references that were used throughout this project, but also particularly the ones cited on this presentation here that you could certainly look at for more information on this topic. Thank you for your time and your support throughout this. This is a project that's certainly not over, but we are very proud of at this moment at our facility, and we look forward to continuing to improve the process of mobilizing our patients and getting them on the way to recovery in a much faster, safer manner. Thank you and have a great day.